All right, I think we're all right to get started. Thank you, everyone, for joining us. My name's Kellie McLain. A couple of housekeeping notes at first. When you join, just make sure you're muted. Um, we will have time at the end for questions. However, we have a hard stop at 8 o'clock. And there will also be a link in the chat discussion for CME credit. If you want to click on that after or during the presentation. So we've got a wonderful talk tonight about managing triglycerides in 2024 by Dr. Jaime Burkle. He's a fellow of the American College of Cardiology and the National Lipid Association. He's an associate professor of medicine at Augusta University and the University of Georgia, and currently serves as the director for the Center of Cardiovascular Prevention, Metabolism, and Lipids at Georgia Heart Institute, as well as chair of cardiology at Atria Institute. Dr. Burkle received his medical degree from LaSalle University School of Medicine in Mexico City, where he graduated with honors cum laude. He completed his residency in internal medicine and fellowship in cardiovascular diseases at Mount Sinai Medical Center in Florida, as well as advanced cardiac imaging at the Mass General. Dr. Burkle specializes in cardiovascular prevention and lipid disorders. He holds 6 board certifications, including cardiovascular diseases, internal medicine, clinical lipidology, echocardiography, nuclear cardiology, and vascular imaging. He has written medical textbooks and has published numerous articles in cardiovascular medicine and lipid disorders, and also participates in clinical research where he is principal investigator of a number of trials. So we are very happy to have you here, Dr. Burkle. Thank you for speaking tonight, and I will give it to you. If everybody will make sure they're muted, please. Thank you.
Thank you so much, Kellie, for the warm introduction. I'm so happy to participate in this activity. And yes, like we were talking earlier, I think that everyone is very comfortable managing hyperlipidemia and elevated LDL cholesterol. But when it comes with triglycerides, I think that there's a gap in knowledge. So hopefully tonight we're all going to be on the same page when it comes to approaching diagnosis and management of these challenging patients. So these are my disclosures. So why are triglycerides important? Well, turns out that if we go back over 20 years ago, we learned that patients with dyslipidemia, having low HDL cholesterol was a risk factor. But when you account for both low HDL and high triglycerides, you get a 17.2 increase in the odds ratio for atherosclerotic cardiovascular events. So for over 2 decades, we've learned the importance of having elevated triglycerides as being a significant risk factor. And also, when you look at the different components of the metabolic syndrome, you also realize that when it comes to high triglycerides, having low HDL, high blood pressure, high glucose, high BMI, or the metabolic syndrome per se, having high triglycerides above 500 confers an extremely high risk for development of atherosclerotic cardiovascular disease and acute events in general. So what is the mechanism of atherogenesis then? Well, there are 4 postulated mechanisms for atherogenesis: subendothelial infiltration, endothelial dysfunction, inflammation, and activation of the coagulation cascade. Let's explore each one of them individually. So subendothelial infiltration occurs when triglyceride-rich lipoproteins are exposed to lipoprotein lipase, the most important enzyme in triglyceride metabolism. This enzyme will actually remove triglycerides from these particles and form triglyceride-rich lipoprotein remnants. And these remnants are small enough to penetrate this subendothelial space, and very much like LDL cholesterol, are taken up by macrophages, form cells, activate the whole inflammatory cascade, and form plaque. In addition, They have a direct effect on inflammation, coagulation, and endothelial dysfunction, which activates platelets and activates monocytes, which increases the recruitment of monocytes in the subendothelial space to perpetuate the inflammatory milieu of the plaque. So again, triglyceride-rich lipoprotein remnants are as atherogenic as LDL cholesterol. The second mechanism is inflammation. It turns out that hyperhomocystinemia, oxidized LDL, glycated LDL, hydroxylated LDL, dietary lipids, hyperglycemia, and N-acetyl glucosamine, all of them increase endothelial derived stress with increased inflammation and increased oxidation, all causing endothelial dysfunction. And we all know what are the consequences of this: increased vasoconstriction, increased oxidative stress, platelet aggregation, vascular leakage, inflammatory burden, and increased leukocyte adhesion. So all these effects that are mediated with oxidized LDL and also dietary lipids can cause endothelial dysfunction. The third mechanism is inflammation per se. Turns out that free fatty acids, in addition to modified LDL and oxidized LDL, can actually stimulate the inflammation through the NLRP3 inflammasome. And this will all increase the production of pro-interleukins and ultimately the production of interleukin-1 and interleukin-18. Both of them are directly related to inflammation. So yes, they're pro-inflammatory as well. And finally, it's been actually associated as well with both the activation of the intrinsic and the extrinsic pathway in the coagulation cascade, which ultimately converts prothrombin into thrombin and can actually cause procoagulation in this patient. So those four mechanisms are implicated in the increased risk for acute cardiovascular events. But the question is, why do we get high triglycerides? Well, and that's the first question. The second question is, how come not every obese diabetic patient has hypertriglyceridemia? And the reason is, well, we need to understand triglyceride metabolism to answer that question. And it turns out that when we eat, all food is processed in the small bowel, and as you know, the small bowel and the enterocyte will produce chylomicrons. And the chylomicrons will be absorbed in the lymph, going to the circulation. And once in the circulation, chylomicrons, which are very large triglyceride-rich particles, will be exposed again to the key enzyme, lipoprotein lipase, which is going to take fatty acids and give it to muscle for energy, and is give it to fat for storage, but it's going to produce chylomicron remnants. And these chylomicron remnants are going to go to the LDL receptor in the liver and get recycled. And if produced in excess, like we mentioned, is going to produce atherogenesis. But the key step is always lipoprotein lipase. Lipoprotein lipase is going to be very activated in the presence of chylomicrons in the circulation. If we look at the intrinsic pathway, the liver is going to form VLDL, as we know, and this VLDL is going to be very much like a chylomicron exposed to lipoprotein lipase, and this lipoprotein lipase will again take up the fatty acids, give it to muscle and heart for energy, and adipose tissue for storage, and this VLDL remnants, also known as IDLs, will then go back to the liver for circulation. So once again, lipoprotein lipase is the key enzyme in this metabolism of triglyceride-rich lipoproteins. And not only we know that is the key enzyme, but also know that there are potent inhibitors in the circulation for lipoprotein lipase. The two most important ones being ApoC3 and the angiopoietin-like proteins NPTL3 and NPTL3 and 4. So ApoC3 and these angiopoietin-like particles have a significant effect on lipoprotein lipase by inhibiting its action. So what are the key elements for physiologic triglyceride levels? Well, first and foremost, we need to have normal glucose levels. We need to have a low amount of chylomicrons and a low amount of VLDL. Then we need a high lipoprotein lipase activity to break those down and high endothelial lipase activity. And finally, we need low levels of the inhibitors of lipoprotein lipase, those being ApoC3, ANGPTL3, and ANGPTL4. And finally, a high number of hepatic remnant receptors. If you have all those factors in and they're working appropriately, your triglyceride levels will be normal. If you have any of those that are off, then your triglyceride levels will be elevated. So what are the take-home points at this point? First, lipoprotein lipase is the most important enzyme in triglyceride metabolism. Second, high levels of lipoprotein lipase clear chylomicrons, and VLDL very effectively. Third, ApoC3 and HPTL3 are the most potent inhibitors of lipoprotein lipase. Four, obesity, hyperglycemia, and insulin resistance all induce ApoC3 production and therefore inhibition of lipoprotein lipase. And finally, inhibitors of ApoC3 and HPTL3 greatly increase LPL activity and therefore decrease triglycerides. We'll talk about this later when we talk about management. Let's move on now and talk about how do we classify hypertriglyceridemia. Well, there are several classifications. The American College of Cardiology and the American Heart Association classify them in three groups: normal triglycerides, less than 150 milligrams per deciliter, high triglycerides, 150 to 499, and severe hypertriglyceridemia above 500 milligrams per deciliter. But there are other classifications like the ATP3 or the Endocrine Society of America. I particularly like the Endocrine Society of America that classifies hypertriglyceridemia in mild, 150 to 199, moderate, 200 to 999, severe, 1,000 to 199, 1,999, and very severe when it's over 2,000. This classification is particularly interesting because it also ranks the risk for atherosclerotic cardiovascular disease or risk of pancreatitis when you have severe hypertriglyceridemia, which in essence is chylomicronemia. So now, how do we approach hypertriglyceridemia in clinic? A patient comes to see us in our clinic, triglyceride levels are 400. How are we going to approach that? First and foremost, the most important first step is always rule out secondary causes. There are certain medications that can cause hypertriglyceridemia. Hypothyroidism increases LDL and increases triglycerides as well. Alcohol intake, very known cause of hypertriglyceridemia and increased HDL. Patients with hepatocellular disease can have hypertriglyceridemia. Chronic kidney disease can cause hyperlipidemia, increased LDL, low HDL, and high triglycerides. Obviously, pregnancy is a big one, hypertriglyceridemia, which is physiologic. Diabetes and metabolic syndrome, like I was mentioning earlier, they have increased ApoC3 production and therefore decreased lipoprotein lipase activity and therefore high triglycerides and low HDL. And finally, poor diet and obesity, which causes both increase in triglycerides and HDL. So always remember, rule out secondary causes. Insulin resistance, visceral adiposity is a common risk factor for this. Now, for alcohol intake, we talked about this, increased liver production of fatty acids. Medications, always look at the medication list on your patients. Many antipsychotic, of course, antiretroviral therapy, particularly protease inhibitors, some beta blockers, bile acid resins, corticosteroids, estrogen, immunosuppressants, isotretinoin, and thiazide diuretic can cause hypertriglyceridemia. We talked about hypothyroidism. We have the so-called hypothyroidism-related dyslipidemia, chronic kidney disease, liver disease, pregnancy, autoimmune disorders. And of course, we have patients with primary hypertriglyceridemia that have the familial chylomicronemia syndrome or could have this beta lipoproteinemia. And in these cases, these are genetic disorders that predispose to the condition. So what are the goals of treatment of hypertriglyceridemia in 2024? First, we need to distinguish patients who have large amount of chylomicron particles in the blood because of the inability to clear large particles containing triglycerides are very high risk for pancreatitis. These are patients that have triglyceride levels above 1,000, 2,000, or 5,000. So a defect in lipoprotein lipase that is most typically congenital will result in severe hypertriglyceridemia, also known as chylomicronemia, and that will increase the risk of pancreatitis. On the other hand, patients with moderate hypertriglyceridemia in the 200 to 500 range they have accumulation of remnant particles, triglyceride-rich lipoprotein remnants, and they are at risk of atherosclerotic cardiovascular disease in a way very similar to elevated LDL cholesterol. So we need to start by making that big distinction. This is the algorithm that has been proposed by the ACC on how to approach patients with hypertriglyceridemia. You always start with calculating your 10-year ASCVD risk score by your pooled cohort equation. You initiate lifestyle modification, assess for secondary factors, review medications to rule out secondary hypertriglyceridemia, discontinue those that could be culprit. And then you obviously stop at evaluate your LDL cholesterol. So if your LDL is greater than 190, then you immediately shift to the hypercholesterolemia and elevated LDL algorithm. But then if that's not the case, if your LDL is not above 190, then you're going to look and see if your patient has low risk, triglyceride level less than 150, those patients will need just lifestyle modifications and routine surveillance. If the patient has a borderline risk score between 5 and 7.4%, triglyceride levels between 150 and 499, again, you intensify lifestyle modifications and discuss statin use. Intermediate risk patients, 7.5 to 19.9% risk, 10-year risk, and triglyceride levels between 150 and 499, intensify lifestyle modification and initiate statin use for sure. Patients at high atherosclerotic cardiovascular risk greater than 20%, triglyceride levels in the 150 to 499 range, intensify lifestyle modification, consider adding Vascepa to the statin, and this is based on the REDUCE-IT trial. And finally, patients that have triglyceride levels over 500 initiate fibrate therapy to prevent pancreatitis, omega-3, niacin, and intensify lifestyle modifications. So what are the take-home points at this point? Moderate hypertriglyceridemia, that is triglyceride levels between 150 and 500 milligrams per deciliter, causes increased triglyceride-rich lipoprotein remnants, which are atherogenic, like LDL. Moderate hypertriglyceridemia, therefore, increases atherosclerotic cardiovascular risk. Severe hypertriglyceridemia, defined as greater than 500 to 1,000 milligrams per deciliter, means chylomicronemia, and chylomicrons are very large particles, usually in the 300 to 600 nanometers, and this doesn't increase the risk of atherosclerotic cardiovascular disease, but does increase the risk of pancreatitis. So how do we approach management? Diet and exercise. Does it really work? Well, let's look at some of the data. These are epidemiological studies that have shown that weight loss reduces triglycerides up to 70%. And although most patients would likely experience reduction in triglyceride levels of 10 to 20% in weight loss, there's evidence that in many patients, especially those that have elevated ApoC3 levels, there's a significant reduction in triglyceride levels up to 70% that can be achieved. Dietary modifications, including alcohol restriction, may cause a greater than 70% reduction in triglycerides. Reports may vary, of course. And physical activity and exercise, up to 30% reduction in triglycerides. So if you consider lifestyle modifications, that should be always the first step in the management of patients with hypertriglyceridemia at any level. And this is another algorithm that we like using in adults with fasting triglyceride levels greater than 150 or non-fasting greater than 175. Always assess for secondary causes, always lifestyle, and emphasize a good dietary pattern and increase physical activity. If the triglyceride levels are less than 500, these are the dietary modifications that we recommend. Less than 6% added sugars, 30 to 35% total fat, and restrict alcohol. But if we go on the other hand and your triglyceride levels are over 1,000, you have to eliminate completely added sugars and starches. You want to limit your total fat intake to 10 to 15% and abstain completely from alcohol. Obviously, you're going to encourage activity and weight loss and monitor for response. How about pharmacologic therapy? What are the drugs indicated for the treatment of hypertriglyceridemia? Starting out with fibrates. Fibrates result in a 25 up to 50% reduction in triglycerides with some increase in HDL 5 to 20%. Omega-3s 20 to 50% triglyceride reduction with increase to no change in HDL, but some omega-3s, especially DHA, may cause an increase in LDL 5 to 10%. EPA, on the other hand, or icosapent ethyl, reduces triglycerides 20 to 50%, may increase or no change HDL, but in some instances may increase LDL, although typically we don't see a significant increase in LDL cholesterol. Statins, 10 to 20% reduction, discrete reduction in triglycerides, and obviously a significant reduction in LDL cholesterol. And our old friend niacin, although it is not very commonly prescribed nowadays, it can reduce triglycerides 10 to 35% in some instances. Now, I was mentioning the REDUCE-IT trial. This is a very important trial that Deepak Bhatt presented at the ACC in 2019. They took patients with established cardiovascular disease or diabetics with multiple risk factors. They had a fasting triglyceride level greater than 135 and LDL less than 500, and they all had to be on statin therapy with a relatively fairly well-controlled LDL cholesterol. Patients were randomized to receive icosapent ethyl 4 grams a day versus placebo, and the primary endpoint was a composite of cardiovascular death, non-fatal MI, non-fatal stroke, coronary revascularization, or hospitalization for unstable angina, with a key secondary endpoint of cardiovascular death, non-fatal MI, and non-fatal stroke. These are the results. The trial resulted in a statistically significant reduction of 30% in the triple endpoint of cardiovascular death, non-fatal MI, and non-fatal stroke, with the addition of icosapent ethyl to statins on patients with established cardiovascular disease or diabetics with multiple risk factors, on statin therapy with persistent elevated hypertriglyceridemia. So this should be now standard of care, that all your patients that are on statin therapy with relatively well-controlled LDL, if they have hypertriglyceridemia above 150, they all should be put on icosapent ethyl. So what are the take-home points? Diet, exercise, and weight loss alone can decrease triglyceride levels up to 70%. Statins are always first-line drugs to reduce cardiovascular mortality in patients with hypertriglyceridemia and ASCVD. Icosapent ethyl is indicated to reduce cardiovascular mortality in patients with established ASCVD on statins but with residual hypertriglyceridemia. Fenofibrate decreases the risk of pancreatitis in severe hypertriglyceridemia, but does not decrease cardiovascular mortality. There's no clinical trials that have demonstrated that. And finally, although niacin can reduce triglyceride levels, large-scale trials have failed to demonstrate cardiovascular mortality reduction. Now let's talk about some off-label drugs. Are there any off-label drugs for the management of hypertriglyceridemia? And the answer is yes. These drugs listed in this slide: ezetimibe, PCSK9 inhibitors, GLP-1 receptor agonist, GIP agonist, combined GLP and GIP agonist, and SGLT2 inhibitors in clinical trials have demonstrated effect on triglyceride reduction, although we don't specifically use them for the management of hypertriglyceridemia per se. Ezetimibe, for instance, in clinical trials has demonstrated a discrete, but not a discrete reduction in triglycerides of about 17%. Evolocumab in clinical trials has demonstrated as well a reduction in triglyceride levels of about 25%, 16 to 25%. GLP-1 receptors like semaglutide in both the SUSTAIN-6 and the PIONEER trials have demonstrated a reduction in triglyceride levels over time. GLP-1 and GIP receptor agonists like tirzepatide have also been associated with a reduction in triglyceride levels up to 40%. This is directly related to weight loss, of course. And finally, SGLT2 inhibitors have demonstrated also a not significant, but some reduction in triglycerides in the order of about 12% reduction for dapagliflozin. Finally, what are the future therapies of hypertriglyceridemia? We can divide them in these groups: ApoC3 inhibitors, ANP-3 monoclonal antibodies, and LPL replacement gene therapy. So remember, I told you that lipoprotein lipase was the key enzyme in triglyceride metabolism. Well, apoprotein C3 and ANP-3 are the two most important inhibitors of lipoprotein lipase. So we can inhibit these two, will result in significant increase in lipoprotein lipase activity and therefore triglyceride reduction. So olezarsen is an ApoC3 inhibitor, is an antisense oligonucleotide, and was given fast track designation by the FDA in February of last year. How do antisense oligonucleotide drugs work? There are a single-stranded RNAs that are injected subcutaneously. They get endocytosed in the cell, they get into the nucleus, and they bind to the messenger RNA that is going to produce ApoC3. And by doing that, it destroys the messenger RNA, preventing it from getting out of the nucleus for protein codification. So this is one way that you can actually modify the RNA by giving an antisense oligonucleotide. And in clinical trials, administration of olezarsen every 4 weeks subcutaneously at doses of 60 milligrams result in 83% reduction in ApoC3 and up to 65% reduction in triglycerides. We're participating in the CORE trial, the CORE2 trial, which is a prospective randomized clinical trial on patients older than 18 with triglyceride levels over 500 who are willing to comply with diet and lifestyle modifications. And they should be on lipid-lowering therapy that adhere to the standard of care. So if they have indication for a statin, they also should be on a statin. Patients will be excluded if they are uncontrolled diabetics with an A1C greater than 9.5. If they have transaminases greater than 3 times upper limits of normal, elevated bilirubin, a GFR less than 30, or genetic confirmation of familial chylomicronemia syndrome. Eligible patients are being randomized to olezarsen 50 milligrams subcutaneous every 4 weeks, or 80 milligrams every 4 weeks, and that were then transferred over to an open label extension. So this is an ongoing trial, and it's a phase 3 study, and we're going to keep our eyes open for this trial. The primary endpoint is going to be percentage change in fasting triglycerides from baseline at 6 months, with secondary endpoint percentage change in fasting triglycerides at 12 months, proportion of patients achieving triglycerides less than 500 or less than 880 or less than 1,000 at 6 to 12 months, percentage change in ApoC3 levels, adjudicated acute pancreatitis event rates, both at more than 2 events or during the treatment period. The other agent that we talked about is ANP-3. ANP-3 inhibitors like evolocumab is now indicated for patients with homozygous familial hypercholesterolemia. But ANP-3 inhibitors also have a significant effect, like I said, on inhibiting lipoprotein lipase. So in this clinical trial that was presented by Rob Rosenson at the ACC 3 years ago, it showed that on patients with severe hypertriglyceridemia, randomized to evinacumab 50 milligram per kilogram intravenously every 4 weeks compared to placebo, resulted in a statistical significant reduction in the cohort 3 of triglycerides up to about 60 to 70%. So again, this drug is currently indicated for homozygous FH, but there are ongoing trials now for hypertriglyceridemia. And finally, gene therapy. We have the alipogene tipavarek or Glybera, which is lipoprotein lipase gene therapy. This is indicated for patients with familial chylomicronemia syndrome that have severe recurrent pancreatitis. And basically what we're doing here is we're administering via a vector the gene that codifies for lipoprotein lipase. So this gene is actually transported and taken inside the nucleus of the hepatocyte. And this will in turn codify for lipoprotein lipase. And basically it's one dose and you will fix the enzyme deficiency in patients with FCS that, as you know, they have severe symptoms of recurrent pancreatitis. So in conclusions, hypertriglyceridemia remains one of the most important independent risk factors for ASCVD and acute pancreatitis. Always rule out secondary causes when it comes to approaching patients with hypertriglyceridemia. Diet, exercise, lifestyle modification should always be the first step with up to 77% reduction in triglycerides. Don't forget statins for ASCVD risk reduction if triglycerides are greater than 150, add icosapent ethyl or EPA, and if triglycerides are greater than 500, add fibrates. Early data on GLP-1, GIP agonists look promising. And finally, we're awaiting ApoC3 inhibitors, ANGPTL3 inhibitors, and gene therapy clinical trial results for management of these patients. This is my last slide. I'm going to stop my presentation and entertain any questions you might have.
Thank you, Dr. Burkle. Looks like my computer paused. Can you hear me okay?
I can hear you.
So we've got a couple questions. Thank you so much. That was a very translational talk on discussion on triglycerides. So first question, could you please repeat how DHA impacts lipids?
Yes. So when it comes to omega-3s, DHA and EPA are the two most commonly prescribed omega-3 drugs. DHA causes reduction in triglycerides, but can also increase LDL cholesterol, whereas EPA reduces triglycerides and have very little to no effect on LDL cholesterol. And this might be the reason why clinical trials with EPA have been more successful when it comes to event reduction compared to those utilizing DHA or the combination of DHA and EPA.
Thank you. Next question. Why were patients with FCS excluded from the olezarsen study?
Yeah, that's a great question. And the reason is the reason why olezarsen is now being studied in clinical trials is to approach patients that are high cardiovascular risk, but not the patients that have complete absence of lipoprotein lipase, which are familial chylomicronemia syndrome. So the effect of olezarsen is inhibiting ApoC3, which is the most potent inhibitor of lipoprotein lipase. But if you don't have lipoprotein lipase, then you're going to have any effect from the drug.
Thank you. Next question, and I encourage everybody, if you do have a question, just post it in the chat box at the bottom. What about pioglitazone to help lower triglycerides and orlistat?
Yeah, so there are smaller clinical trials that have demonstrated some beneficial effects on triglycerides. However, the magnitude of triglyceride reduction of those drugs compared to fibrates, to statins, to even niacin is not significantly greater. And for that reason, we don't use them that much in clinical practice.
Perfect. Thank you. Jan McAllister made a very good point. As a reminder, so when triglycerides are over 400, make sure you're ordering direct LDLs if your lab does not automatically do that for you. LabCorp and Quest only have calculated LDL, so direct has to be added. Thank you, Jan.
Thank you. Thank you, Jan. Very good point.
And I have a question. I feel like I've seen a lot of HIV patients, referred for triglyceride management lately. And as we all know, the antiretrovirals will help increase the triglycerides. What is your threshold in discussing with either their primary care or infectious disease provider about switching meds versus adding on multiple other lipid lowering therapies?
Yeah, That's a very good point. So certainly, if triglyceride levels are over 500, I would strongly recommend that the protease inhibitor is either stopped or switched to another antiretroviral drug. Um, and in triglyceride levels lower than 500, I will have a discussion with the patient and with the infectious disease physician to see about other options. But definitely above 500 will be my cutoff for stopping the drug. And obviously, you can also add fibrate therapy. Fibrate therapy actually tends to help those patients as well.
Perfect. Thank you.
Mhm.
Another question, what is the magnitude of reduction of triglycerides with GLP-1 or GLP-1 GIP agonists?
In the order of about 15 to 20% and directly related to weight loss. Again, we don't particularly prescribe those drugs for hypertriglyceridemia. It's just like when you utilize those drugs for weight loss or diabetes, you will see a reduction in triglycerides. So it's like a secondary effect.
Thank you. Dr. Patel asks, which comes first? Triglyceride causes pancreatitis, but GLP-1 agonists help triglycerides. Would you ever use GLP-1 in setting of history of pancreatitis to lower triglycerides? A little
Well,
dilemma.
this question has come up many, many times in both the NLA and the ACC. And the conclusion is if a patient has had pancreatitis, they'll be prone to another episode of pancreatitis, so you stay away from GLP-1 agonist. If the patient has an indication for GLP-1, like I said, for diabetes management due to poorly controlled diabetes or for weight loss, then you will prescribe it and you will get a secondary gain by lowering triglycerides, but you will not prescribe it only to lower the triglycerides.
Great question. I actually had a patient with that issue yesterday.
Mm-hmm. Mm-hmm.
Um, next question. Do SGLT2 inhibitors raise LDL cholesterol? Is that increase clinically significant or hazardous?
So, because of the great effects on cardiovascular event reduction by mostly by both empagliflozin and dapagliflozin, the minimal effect on LDL increase, which is only about 5 to 10% from SGLT2 inhibitors, will not wash off the cardiovascular benefits, and that's been looked at. So I would not withhold uh, an SGLT2 inhibitor when indicated just because it may increase LDL cholesterol. None of the data has shown a deleterious effect on that minimal LDL increase.
Wonderful, thank you. And I think before we started, we were talking a little bit about the importance of dietitians and how backed up they are and overworked they are. Um, just want to remind everybody the importance of referral to dietitians when triglycerides are severely elevated. We also have on the NLA website, lipid.org, the patient tear sheets that give patients a tangible handout for diet management with severely elevated triglycerides. So always remember to check that out. Any other questions that anybody has? If you'll post in the chat. All right. Is the main increase in lipids LDL-C or triglycerides in hypothyroidism? Great.
Both, yeah, you have increase in both. And some patients have more LDL, some patients have more triglycerides, but you expect to have both.
Do you ever see either in hyperthyroidism?
Sometimes we do as well. Yes. I'm sure you've seen it too, right?
Right.
Yeah.
Absolutely.
Yeah.
And other questions, anyone? All right. Well, I want to thank Dr. Burkle for his wonderful discussion about triglycerides. It's always a big topic, and I think we all know what to do most of the time with LDL, but the triglycerides also just kind of baffle us sometimes. I do have one more question that came through. What about the main lipid changes with estrogens and pregnancy?
Yeah, so many times we see that, right? Patients with pregnancy can actually have hypertriglyceridemia. The use of estrogen also may cause, especially without combination of estrogen progesterone, can cause dyslipidemia, but that refers more to LDL than triglycerides themselves. But yeah, triglyceride and a physiologic effect of pregnancy will be an elevated triglyceride level.
Great, thank you.
Yeah.
All right, well, thank you, everyone. We'll finish just a little bit early tonight. Thank you, Dr. Burkle, again for your great presentation. And we hope to see everybody again soon at our next CELA Speaks. That will be to be discussed soon. But thank you, and everybody have a good night.
Thank you, Kellie. Bye-bye.
Bye-bye.